I'm going to be telling you about, once I get my pointer, my work in looking for predictive biomarkers of response to immunotherapy in hepatocellular carcinoma. Apologies if you hear the dogs barking in the background. So I'm over in WA in Perth, and I'm working with the Liver Cancer Collaborative, which is quite a new move. So I've switched labs just recently. So I'm going to tell you about the project that I am currently madly making some data for. Okay, so hepatocellular carcinoma is quite a, let me start that again. There's about 2,000 deaths per year in Australia. And this is actually estimated to rise by about 50% by 2040. And this is both in the incidence and the mortality. And they are both rising quite equally because there are not really effective treatments available for hepatocellular carcinoma at the moment. And the treatments that are available currently are stage specific. So what we have here first is your very early stage. And so the treatment options for this stage are resections and transplantations. And then when you move forward to your intermediate stage, you have your chemoembolization. And then when you get to your advanced stage, you have your combinational approach of atezolizumab and bevacizumab. And what I guess part of the problem here is that about 80% of people are actually diagnosed at this advanced stage. And there is also a high rate of therapy failure. So about 80% of the time, treatments don't actually work. And even if someone is diagnosed at an early stage, so they do get to receive a resection, there is about a 50% chance that they will relapse within 2 years. And all of these combined really leads to this really low 5-year survival rate of 19%. And in WA, it's actually 24%, and it hasn't shifted, and it's not predicted to shift if you remember that step from before. So what this really highlights is that there's a really big need for new treatments for HCC. And one of these that did come about just recently, so in 2020, was this combination of atezolizumab and bevacizumab from this trial, IMbrave 150. And so this was done in comparison to your previous standard of care, which was sorafenib. And what they found was this combinatorial approach really increased overall survival as well as progression-free survival, giving an increased confirmed objective response rate to 30% compared to that previous 11%. But as you can imagine, 30% still isn't great. And when you look at the number of patients that experienced a treatment-related adverse event, it was actually almost everyone. So the question really lies in, what about the other 70% where this current treatment doesn't work? Can we predict who it might work for, or can we make alternative treatments so that these patients don't have to undergo this immunotherapy and likely experience one of these potentially life-threatening and also lifelong adverse related events? So what I'm looking at is trying to identify this blood-based biomarker. So I'm using a really unique cohort from WA that we've curated over here through the Liver Cancer Collaborative, which looks at late-stage immunotherapy patients, which is around 80% of these patients who are receiving immunotherapy. We're taking blood at each immunotherapy time point, and most critically before they actually start, so we have a baseline. And we're going to be looking at blood samples longitudinally. We're going to try and answer two main aims. So the first is to identify some CD8 T cells in the blood that can predict immunotherapy response. So we'll be doing this through single-cell RNA sequencing and TCR sequencing. And then we're going to use a really cool new technology to look at the spatial distribution of some of these immune markers to try and look at how these might change and how they start and how that correlates with immunotherapy response. So for aim 1, we are going to be taking our PBMCs. We're going to enrich for our CD8 T cells. And then we're going to make these into our single cell droplets, about 13 to 16,000 cells per sample. And then we are going to sequence the gene expression and the T cell receptor. So we're going to look at our RNA-seq analyses. So we're going to cluster these CD8 T cells based on their gene expression, and we're going to try and find populations that differ between these responders and non-responders. So perhaps in responders, there might be some more stem-like populations that we see either in high proportion or just present at all in responders versus non-responders. And we're also going to look at their T cell receptors. So we're going to look at essentially the clonality of these. And so what that means is how many different TCRs do we actually see? And are they quite expanded, which we might expect to see in a non-responder, or are they quite diverse, which we expect to see in a responder? And we hope that this will help us to predict who will actually respond to immunotherapy. So our second aim is this really cool new technology that you can see was just accepted only last month, and it's called molecular pixelation. So I'll take you through a little bit of the background of this because it is quite unique, but obviously you can look at this paper for much more detail. So what they look at is polarization and co-localization of 76 markers that they have in their panel. So what they mean by polarization is if you look at a cell surface, are the proteins randomly distributed on the cell surface, or are they specific to an area? Are they quite polarized? So they made this score here. If the score is 0, it means there is completely random distribution. And if it is above 0, it means that there is some level of polarization. So they induce this kind of polarization with your CD3 here, and you can see these high values here, and they can represent it, as you can see in panels C and E. So this is a really cool way of representing one cell. So we're seeing just one cell here. You can see the CD3 expression is really concentrated in one area. And then you can also see CD2 and CD45, where you have the same cell, but they are different. So let me close the door in case you can. Okay, so now if we go back to the co-localization, so now we're looking at are two different markers in the same location together more often than what you would expect by random. So they looked at Europod markers where you would expect these three markers, CD162, 37, and 50, to be co-localized in the same part of the cell surface. And so what you can see in each row is one different cell. So there are 6 examples of cells, and you can see these markers are co-localized together. And then we have some 2 dispersed markers to show you that they are random. So I want to use this technology to really look at the localization of some of these markers that we believe are probably important for immunotherapy response. So just to bring you back to what the immunotherapy was. So it's a combination of bevacizumab, which is your VEGF, which has the aim of normalizing your vasculature as HCC is quite a cold tumor. And then it's in combination with your anti-PD-L1, your atezolizumab, which is aiming at activating T cells and really inducing that T cell activation. So bring your attention to this top right, where again, we're looking at inducing the T cell capacity to kill cancer cells. So some markers that are of interest to us, and I know that if you do know some of these CD8 T cells, it's quite a small list, but these are the markers that are actually in the panel from Pixelgen. And so these are some markers that we will be looking at in particular. So just in summary, we want to identify some CD8 T cells that we can use for predicting immunotherapy response to try and stratify these patients prior to any kind of treatment. And then we want to try and identify the polarization, co-localization of immune markers related to immunotherapy response so that we can try and provide new insights into the mechanism of response and potentially develop a new, more effective treatment for those 70% of people that will not respond to immunotherapy. Cool, thank you.